Hello and welcome everyone. I'm Georgina Sosa and I'm here to share my research about continuity of care in labour, and I feel really honoured to be here. So thank you so much for having me. This is research that I did as part of my PhD. And I hope that it's going to give you the language when you're caring for women, low-risk women in midwife-led birth environments, to give the language of what we do. Because it doesn't look like we're doing a lot when we're in the back in the room and watching women. But there's a lot going on, my research shows. There's loads of evidence to show that a continuity of carer does improve outcomes. That can't be debated. And as well as all the good outcomes, is that women are so much more satisfied with their experience as well, and more resilient to their future with their baby. So I wanted to have a look at how does one-to-one support in labour translate to practice. So what I did, I went to freestanding unit, so it was a midwife-led unit away from the hospital, several miles away, and then I went to a alongside midwife-led unit, which was just a corridor away from the labour ward, and then I went to home births as well. And I also interviewed midwives, and I interviewed the women. And sometimes the partners were there with the women as well, so they did it as a labouring couple. I was there for hours, and I did observations inside the birth environments and also outside the birth environments in the staff rooms. So I observed 10 births at each site, so 10 at the AMU, 10 at the FMU, and then 10 home births as well. There was only one woman that I couldn't follow up postnatally, and also there was 3 notes that went missing, but otherwise I analysed 27 maternity notes. So when women did get the continuity of care, they really loved the experience, and so did midwives. So this woman, Connie, she said it was intimate. The midwife didn't have to worry about anyone else. She just found out all about me, and it was just intense, me and her, and it was as though there was no one else there. Yes, I felt like I was totally trusted, one person, and I totally felt safe with her. And the midwife as well, because she felt she could give 100% of herself. You don't feel guilty that you have to swap yourself in between 3 ladies. I think it's really good care that we're giving here. So what I found that happened when you went into the room, that there was these prerequisites to one-to-one support in labour, to continuity of carer. And if any of these prerequisites were not there, it just couldn't happen. Okay, so first of all, you had to have a ratio of 1 woman to 1 midwife. And then the midwife had to be present, and she had to be motivated to be present. I think you know what I'm saying when I say that. And then with her presence, she was able to focus on the woman. And when she was able to focus, she could tune into the needs of the woman. And this is where the magic started happening then, because right at the end, she was balancing 6 components. But to get to that point, she had to have these prerequisites. And the midwife had to be knowledgeable as well and use her experience to guide her actions. And what I found is that junior midwives had intuition, but they didn't believe in it. But as we get older with experience, we learn to trust our intuition. So midwives did use that a lot. So I'm going to focus this presentation on these 6 components that midwives balance. And in the room, midwives felt really autonomous and safe and good about their practice. Outside the room, you can see that they're also balancing the needs of the organisation. That's a whole different talk, but I have got a poster that shows about territorial behaviours. But inside the room, this was not disturbed by things that were happening outside in all the 3 sites. So each of these 6 components had a continuum, and I'm going to go through each of those. So the balance the midwife was doing was an equal relationship with the woman. So the midwife didn't always get the balance right, but that's okay because it's an equal relationship. So the woman sometimes synchronized the care so she got what she needed. But what I want to show you today is having a continuity of carer is not just about a ratio of one midwife to one woman. It is about balance. And it's an equal relationship. So I'm going to introduce you to Connie and Diana. That's not their real names, but this is a real observation. Now, some labours you go in, they're so quiet, isn't it? And you need to be quiet as a midwife. But this labour was not like that. It was so vibrant that actually to go in there and just introduce myself like, Connie, is it still okay that I come in here? I had to be loud because the music was blaring. There was music going on and the woman was moving to the music and so was the midwife. And there was a lot of that going on for many hours. And the midwife was really interactive with her. Every single contraction, she was saying, you're doing well, well done, keep going. And the woman liked that. She needed it. And there was a time then that the woman was in the pool and things were calmer. But then there was a point that the baby's heartbeat got tachycardic, so they had to transfer to labour ward. But the midwife tried to keep that calmness, but it was hard because they got disturbed several times for progress reports, which they didn't have when they was in the AMU. So I'm giving you that background information because I'm going to go through the continuums of these 6 components, but I'm going to use them as an example as we go through so you see them in real life. So the first component that the midwife is balancing is presence. So some women want you in their 1 meter space, very close to them, sometimes very interactive. Sometimes the woman wants you there close, but she wants you to be absolutely quiet. Other times, she wants you in the room, but away, way in the distance, or in another room in her home. And again, she wants you very quiet. Sometimes the midwife picks up, actually, the woman needs privacy, so she will actually leave the AMU or FMU birthing environment, or the woman herself will go into another room if she's in the home birth situation. If the midwife doesn't balance it right, women hide from us. Okay, that's what they admit. They say, oh, I sneakily go into the bathroom and then I speak to my partner there to think about my progress in labour. But sometimes the midwife, when she left the room, it was only to come back to do clinical observations. And the reason for this, for example, was in the FMU, sometimes the midwife was working there on her own and she'll be doing an antenatal clinic. And if a woman came in labour, then she had to balance those risks and think, does the woman need me 100% in labour, or can I continue the antenatal clinic while I'm waiting for midwifery support to come? So sometimes that midwifery support wouldn't come until an hour and a half later. So you can imagine that caused midwives quite a lot of anxiety at times. So this is one of my drawings, live in action in the AMU. And you can see that Connie says here, I kind of almost waited for her voice because there had been a system going on as I breathed through every contraction. And I knew her voice would be there. And it was so reassuring. And I needed that. And she didn't even miss one. And it meant everything. Yes, it was just brilliant hearing her, the midwife's voice. And the midwife, when they responded to this, they usually took it from the woman's perspective. So they had an understanding that if they wasn't there, then the woman would feel lost. She would feel frightened with anxiety as well. So she needs to feel confident, so she needs to have the midwife there. Now, the midwife-woman relationship. On one side, you had commitment. Now, sometimes you feel so committed to a woman that you don't want to leave her, do you? Sometimes you'll stay after your shift. And I'm not saying you're not committed when you don't stay after your shift, but sometimes you feel that the outcome is going to change if you don't stay with the woman. Other times, women have said, you're like a friend to me. You're like part of the family, just for that short time. But for most women, they talk about this mutual trust, like I've said before, that it's an equal responsibility, that we believe in the woman's can birth and the woman believes in our professional knowledge. But we both need to take a break from each other sometimes, like I said. And sometimes the midwife also, she would leave the AMU room or the FMU birth environment just for a short time. Or in a home birth, she would even sit on the doorstep just to get some fresh air and just a break from the situation. But sometimes in a relationship, the trust was lost. And what I did find is that once the trust was lost, it was gone. And what parents did was just wait it out and waited for the next midwife to come on shift. Closure is really a difficult time for women. They don't want you to go. They want to thank you. They want to go through the labour with you. So seeing you postnatally, they love that. They love seeing your face and talking through the labour. And they love telling me their stories because I had been in their labour. So reflecting on the woman-midwife relationship, Connie said, Diana became my friend. I felt like I'd known her for ages, and we found out all about each other. If I had someone who didn't want to communicate, that would have changed the whole experience for me. So I think midwives who's going to give one-to-one care, they need to be prepared to be good communicators. And the midwife as well said, because she did actually stay late, and there was a few minutes that she thought the woman had a third-degree tear. So staying late after her 12-hour shift, she started to question, should I have actually? Maybe she would have been better with a fresh midwife. So that's why she said, I felt really involved. I wasn't sure that I did the right thing to stay over the time. But you know, there are the kind of things that you don't have answers. You just do what you feel. And if I had that time, that situation again, I would do the same thing. Labour progress. Now, with labour progress, sometimes you just had about enough time to put your gloves on, isn't it? You can't do anything else but follow the woman's progress. But other times, midwives were very sure that labour was following normal progress, so they didn't intervene in any way. Other times, midwives would question the progress a little bit and think, do you want some honey and some water? Do you want some toast? Let's walk you around. Should we go up and down some stairs? But other times, midwives started giving instructions how to push and what positions to go in, and some women loved it. Some women said, you know what, I wouldn't have been able to do it without her. You know, last time they didn't give me any advice at all. This time they told me how to breathe, how to push, and they love it. But some women took it as dictatorial instructions, and they had this vibe that was escalating, that there was this urgency that they have to get the baby out as quick as possible. So it made them really anxious. They didn't understand all the time why there was this urgency. And then they were being told to push, that's it, keep breathing, and then push, more. And they got really frightened by these instructions. And afterwards, they would question, should I have listened to the midwife's instructions, actually? Did I get the result that I wanted? And if at the end, the balance couldn't be achieved, sometimes either the woman would ask to go into hospital or the midwife would advise. So looking at the reflection here, Connie says the midwife was trying to reassure me that we were getting somewhere. She was obviously the expert, but she would constantly ask how I was feeling. It would make me get in tune with my body, really. She was obviously pushing me to keep communicating with her constantly about the changes or anything that might be happening in my body. So I felt free to express my feelings, and she encouraged that. And then the midwife said, women are the ones that lead the labour, not me. I'm a midwife. I have the skills to understand if the progress is going on or not, but they can feel it without me saying something. So I think the question I ask women in labour are the way to remind women to feel their body. Coping. Now, this was the one that the women really synchronized for themselves, because most of the time, reassurance, saying to a woman, you're doing brilliant, well done, this worked for the majority. And whether it was subdued, that was only when it was needed, or every single contraction. But for some women, there was a point that reassurance wasn't enough anymore. They wanted assurance that the birth was going to happen soon. So you know that time, when's it going to be over? And then some midwife said, how long is a piece of string? That didn't go down very well. And then other midwives would say, within about 30 minutes. 30 minutes? I can't do 30 minutes. That's it. I want to go to hospital. But those women, most of the time, did have their babies within 30 minutes. But if they didn't, then women often gave themselves a talking to, like, what's the worth of me panicking now? I've got to put myself in order. This is not going to help me and the baby. And if that didn't work, then they would start asking us to do interventions. Can you check how many centimetres I am? Because that will help me make a decision whether I want to go into hospital. Can you break my waters? That's what they did last time. That will help me go faster. Otherwise, if none of that worked, then the woman would ask to go into hospital or the midwife would advise it. So again, with Connie, she said, the midwife just kept me calm the whole way through, and I thought there's no point if I get stressed now. If I get upset now, this is going to make it worse for me and the baby. I just thought, well, I have got to. I've just get on. Business-like, really, and not get all emotional about it. And I remember feeling more and more, but I felt determined the whole way through. I thought, I'm not giving in. We've got to carry on. And this was in the labour ward here. The birthing partners. Now, have you seen some birthing partners that they don't need no communication in words? It's the look in their eyes. They've got history. It's not just about the present. Their actions are from their history and have consequences for the future. And some partners, they collaborate with the midwives. So the midwife will be saying, oh, you're doing really well. But the partner will be saying, darling, I can see the head. So with both of them saying that, the woman knows her husband isn't trained. So if he can see the head and the woman's saying, I'm doing well, it must be happening. But sometimes the women said, sometimes this felt like they were ganging up on me, actually. And I had to remind them, I'm the one that's in labour, remember. Other times, partners wanted to do practical tasks, especially when they were home. They felt really comfortable doing this. They used their experience from previous births, and because they were in their own home, they could get the creature comforts that their partner needed in labour. So they felt much more useful. Either they were filling up the pool as well, or they were being the hostess. They felt really useful. Some partners, when the midwife was out of the room, started mimicking the midwives. So they would say, you're doing really well, darling, well done. But some would take it a step further, so that when the midwife was out of the room and the woman said, darling, does that tear look big? The partner would say, I'm not going to lie to you, darling, it does. So that caused a lot of anxiety, because you can imagine they didn't always have the sensitivity that we would have. Some couples made predetermined plans. So like for one couple, they arranged that the husband would sleep for the whole labour because they felt it was going to be a long night. She'd had 3 daughters previously, so his snoring could be heard the whole labour. And actually it was really reassuring. But when the woman woke him up, she had the baby within half an hour. And then straight away, he was working in collaboration with the midwife. Darling, this is what you did last time. This is excellent. You're going to have the baby soon. And the midwife was meeting the woman for the first time. So this was good collaborative work. And afterwards, he could then go and collect their 3 daughters and look after them. So this worked out really well for them. But some partners felt really vulnerable. Especially in the AMUs, there was nowhere for them to go. They were there 100% of the time. If they tried to leave, the woman said, don't go. So I think it was because in the home birth, if they left the birth environment, they were somewhere in the house and they could be called. But if you went outside the AMU, you could be anywhere in the hospital. How long is it going to take you to come back? So the women were very reluctant to let them go, so they got exhausted. At home, they often asked the midwives, I'm just going to sneak off for a little sleep. But they couldn't always do that they couldn't do it at all in the AMU. And sometimes if they lost the trust of the midwife, they felt very stressed as well, because they felt that the onus was on them to be the advocate for the woman. And also, if the midwife went into instructor mode, and the woman was then following the instructions, the husband or the partner used to feel they had to follow the instructions as well. And then there was issues sometimes afterwards when they reflected, because the woman said, he didn't say what we wanted. So it does put to question if there could be long-term effects for their partnership. But here, the partner, he thought he was going to turn up with 2 magazines and read them at the back of the room. But actually, the midwife spoke with him, and he was very shy at first. But for the whole of the labour, like he says here, I was doing the massage for the whole of the labour, and he'd done it really well. And the midwife picked up on his shyness, and she said, I think it's important to involve him. It's not just the woman that is delivering. It is also part of his life. And I asked them to massage the woman, not because I don't want to, but because it's a way to involve them, especially those that are not talking too much. So I can try to ask them to, so that they can ask them to communicate with the touch. And then the last one that the midwives were balancing is midwifery support. Now, midwives felt the happiest when they had midwifery support that was accessible, really easily accessible, like you open a door and you've got your colleagues there, or within at least half an hour. And they shared the same philosophy of care as you, so that you could go out and say, you know, I've got this situation. What do you think? Would you do the same? Or actually ask advice. Sometimes they would ask for guidance, especially junior midwives. Could you come in and do this and I watch you do that? Or could you watch me do this? So that was really reassuring. Other times the support was not so welcomed. This usually happened when there was a change of shift. So if one midwife said, I'm going to stay after my shift, then there was 2 people giving continuity of care. And the midwife that had been on all day, the woman was tuned into her voice. So the midwife trying to take over just felt that she couldn't be part of the birthing experience until the other midwife went home. Then there was the unpredictable support. So like I said, in the FMU, sometimes it was an hour and a half before the midwives could get to them. So that made the midwives very stressed, and sometimes they would call the midwife in much earlier than they usually would do, just to make sure the midwife was there when needed. Then the one on the far end, conditional support. This is when midwives became gatekeepers to the support and said, if they were on call, they would say, yes, I will come out, but you need to do a vaginal examination beforehand, because I need to know that the woman's in established labour. This put midwives in a really dodgy position, and they felt bullied a lot of the time when this happened, because they felt, actually, I've been given midwifery-led care, I can see the woman is progressing, I don't need to do a vaginal examination, but actually to get this midwifery support, they're saying that they won't come to support me unless I do this. So it's a very difficult situation. But here for Connie, when she had that few minutes that they thought it was a 3rd-degree tear, you went from just having 4 of us in the room to all of a sudden about 10 people in the room. Because there was people bringing in equipment and they were getting the woman in lithotomy. But Connie picks up on this and says, when all those doctors came in and the spotlight came in and I was there in stirrups, stitching and all that, I didn't really care because the baby was out. At that point, it was kind of funny, really. This man popped his head around the curtains and said, you know, I'm really sorry, but I need to... And I said, yeah, fill your boots, you know. By that point, I thought, yeah, you know. And what I found is that when the balance was right, the women were so resilient to whatever happened in the future. And the midwife here, she reports on the disturbance as well when she went to labour ward. She said, it's so important for us to know that a colleague is outside to support you. But when I was in the labour ward, they kept knocking on the door, asking if I wanted to go home, also to know about the progress. And I really felt the one-to-one support was disturbed. I felt upset because it was this really important moment. I couldn't follow her as I would have done because I was continually going out and in and out and in and out. But overall, with Connie, she really loved her midwife. She was in awe of her midwife. And she said the care for both of us was fantastic. He, her partner, felt so emotional about our midwife, and the whole experience, really, we felt that we'd had gone through that whole thing together. We felt so in awe of her midwife. We felt that she was so special. So in the end, I hope I convinced you that continuity of care is more than a ratio. It is a balance. And it is an equal balance with the woman and the midwife. And midwives feel really supported to give continuity of care in midwife-led birth environments if they have support that is accessible to them, and the staff are familiar with the birth environment and they share the same philosophy of care. Now, I have developed some leaflets for student midwives that I'm hoping to write a paper for Sheena's magazine so that we can help student midwives to critically think about these 6 components being balanced in the birth environment. So in the end, I think we should prescribe continuity of care. It makes sense, doesn't it? We have good outcomes all round. And it is a skill, and it is intuitive as we get more and more experience. And it is entrepreneurial skill, and we should be proud of that. Thank you very much.